You're on mute.
I moved my dad so in case John comes out, he won't get seen, but I didn't like look to see what was around me.
Oh gosh. All right.
There's my office mate, my sofa mate out here.
Aw, I don't have anything nearly as interesting as that. I have like just, you know,
sorts of stuff around me right now.
Lots of paper on the floor and things like that. Nice one, Russ.
Jerry Garcia made an appearance.
I'm not surprised. So do you guys know how to use the, you should be able to get on the shared screen. Let me make you, well, I'm the host, but you guys are both panelists.
I should be able to. Oh, yep. I need you to let me share.
You have the newest, latest version of the PowerPoint, Priya?
I believe so.
The one that Steve sent today?
Yes.
With all the little fixes that I asked him to fix. Good.
Yeah.
It says final at the end of it.
It does. Yes, I do have that. 513 final.
And Diane, I'm promoting you to panelist in the event you want to field any questions or anything like that. I think, can you unmute yourself, Diane? Are you able to do that? I just want to make sure.
Yeah, here I am.
Okay, okay, good. All right, I just wanted to make sure.
I'm just going to double check on the number of people who registered yesterday. It was 87. So
I had a lot of
last minute.
Yeah, there was a ton of registrations coming in like all the last 2 days for me. So I know people figured out how to do it.
Do you have them register? Do you have them register through Zoom?
Mm-hmm.
Yeah, they register both on Constant Contact and through Zoom.
Okay.
When I send the link, and I sent the link yesterday and today.
Yeah, a ton of them accessed it and registered.
Yeah.
And I got
See if we can't confuse them.
One person emailing me asking how to access it by phone. There shouldn't be a passcode or anything, so no one should have to enter a passcode to get it.
There was no phone number for it other than the speaker invitation that I got. So
there is a phone number with it. They should have received it with their registration.
Oh, with the registration, gotcha.
Yeah, they should have gotten it. So they know that there's a phone number, but there's not a passcode. You just dial in the number and then it connects you right to the webinar.
Cool. All right, yep, 87.
Hmm?
There are 87 people registered.
Okay. Well, we have like 11 minutes to go, so I'm sure people will start trickling in.
Looks like we have 3 people.
Mm-hmm. Or I'll keep a look on my email because I did get an email this morning about it that I responded to. I answered that question. Okay, Russ got in. All righty.
Oh, I don't like that. trying to orient myself and I don't.
Yeah, you're more of the Zoom meister, Priya. So you're going to share your screen with PowerPoint?
Yeah, once Chelsea enables me to do so, I will share it.
Are you
I'm
able
trying
to
to-
do it?
I'm trying to figure out my screen situation because,
Here, I'm gonna make you the co-host.
oh, okay.
So I think you should see in the bar a share screen option, and then I'm gonna do this here. All right, did it pop up for you?
It did. Oh, perfect.
Okay, cool.
There we go.
Do you guys see it? Russ, do you see the whole presentation?
Yeah, it's completely text to screen. We're on the side.
Okay.
As opposed to on the top. I don't know. It doesn't matter to me. Do I control that how I want to do that?
I think in your layout you can control it.
Mhm.
I just don't.
Went away.
Hide video panel.
We're at the top now. It's good. There.
Okay, it looks like we have 15 attendees logged in. So I think people will kind of continue trickling in. So we could give people about, I don't know, what do you think, like three minutes or something like that, just to kind of get settled and get logged in?
Sure. If we could actually have, Chelsea, it would be helpful for us to know kind of what organization everybody's from and kind of what their role is.
Yeah, sure. So for those of you who are in the webinar already, could you go into the chat and write your name, organization that you're attending from? That would be great. And I can kind of just, read off and look at a couple of those. Great. We have somebody from the Providence Center, Paul's Place, Mars Coordinating Center, Frederick County. It looks like we have a lot of people from service provider agencies. Great. MDH. Penrose, so we have someone from a property management company. Hey, Paula from Housing Opportunities Commission of Montgomery County. Montgomery County AAA. Okay. So yeah, it sounds like a lot of service agencies. Hey, Rochelle, Disability Rights Maryland. Okay, we have more people coming in. There's 23 logged in right now. So I'll give it one more minute and then I'll get started with introductions. Hey, Abiola.
And then before you start, maybe because you're gonna have more people on the that have already logged in, just say one more time to put their name and where they're from over there.
Yeah,
People will
yeah.
get the picture. Those
I'll
come
do
after.
a little housekeeping reminder for folks who are attending. Great, welcome Independence Now. So for those of you who are just now kind of logging into the webinar, we are putting our names and organizations you are from in the chat. And I'm just monitoring that. Somebody from the Housing Commission, great. Welcome. Okay, very good. Well, it is 1:03 my time. So we will go ahead and get started. Thank you for everyone putting your information in the chat. For those of you who are just joining us now, we are again putting our names and the agencies that we are attending from in the chat. So go ahead and do that just so we know who is on the call today and have a good idea of what kind of information we might need to focus on or go over depending on who's attending. So welcome everyone. Thanks for joining us this afternoon. My name is Chelsea Heyman. I work for the Maryland Department of Disabilities. And this is a presentation by our good friends and partners at the Behavioral Health Administration. So thank you both to Russ Springham and Priya
Okay. Arokiaswamy. You're good.
So thank you both for doing this presentation. We will be doing a discussion and overview of the public behavioral health system. So I am really excited that you guys are able to join us. Just some housekeeping. If you have a question, put your questions in the Q&A. That's something that I'll be monitoring. And if it's something that I can somehow answer during this presentation or one of the panelists can answer, we'll go ahead and answer it. If it's something that we can't answer, we'll go ahead and address it at the end. If you are joining by phone, so I believe I have a couple of phone only attendees, I can allow you to talk at the end. So what I'll do during the Q&A session for my phone attendees, it looks like it's actually maybe only one person attending by phone. I will unmute you, and if you have I'll ask if you have a question, and if you don't, that's fine too. So you're welcome to also ask questions that way. If you're in Zoom, there is a way to raise your hand. That's going to be in your control settings, the bar that's across the bottom of the screen. There is a raise hand button available down there. I will start the thanks Abiola for asking about captioning. I'm going to start the captioning once our presenters get on. Here, let me put it on now, actually. I will do auto transcription, so you should be able to see captions now. Let me know. Can you see them?
I can see them, but I don't know if
Okay,
it's-
okay, excellent.
Yeah,
So
it's a
sorry about
panelist.
that. I have the captions on now. And without further ado, Priya, you can take it away.
Thank you, Chelsea. So my name is Priya Arokiaswamy. I work for the behavioral health system here, or behavioral health administration here in Maryland. And I will let Russ, my title is I'm the assistant director of evidence-based practices, housing, and recovery supports. So we cover a lot of the services that are mentioned here, and the services that Russ and I don't directly oversee, our colleagues at the department or at the administration does. So, Russ?
Hi, and I'm Russ Springham. I also work in the same office with Priya, and I'm the housing coordinator. And as part of my role, I work with Chelsea and others on the Maryland Partnership for Affordable Housing, which I believe is the who we're with today, right? Yeah.
Yes. All right. So we're going to go over a very brief overview of the public behavioral health system, and we'll probably refer to it as the PBHS. We'll try not to use many acronyms, but if we do, if you guys just, let us know in the chat box, and we will let you know what that acronym stands for. Unfortunately, we all speak in with acronyms, and sometimes it's hard to get out of that habit. So here we go. No. Okay. Oops, not too fast. Okay. So this is just the learning objectives for today. We just want to make sure that you guys have an overview of the public behavioral health system, see what services are offered through the public behavioral health services, as well as what that eligibility for services are and how to access those services. So the Behavioral Health Administration in 2014 is the consolidated entity of the Mental Hygiene Administration, which was known as MHA, and the Alcohol and Drug Abuse Administration, which was ADAA. So in 2014, both those entities merged, and we have the Behavioral Health Administration, which oversees both substance use services as well as mental health services. This is just the mission of and vision of BHA. I'm not going to read that to you guys. So for the public behavioral health system, there are the 3 administrative entities. One is BHA at the state level. And then at our local levels, we have what are called core service agencies. local addiction authorities, and the local behavioral health authorities, or LBHAs. The core service agencies, there are mental health agencies, and then if you have a core service agency in your county, you would also have a local addiction authority as well as in your county. If the core service agency and the local administration or addiction authority merged, it's known what it is called as the local behavioral health authority. So those are the three different organizations that you may hear about who oversee the public behavioral health system at the local levels. And then we have an administrative service organization known as the ASO. Currently that contract is with Optum, Maryland, and they're the ones who approve authorized services for a participant when a vendor or provider puts those services into the system and make sure they're eligible for the service. So this is just the role and function of BHA. I'm not going to read all of them, but BHA, we have a unit that licenses and accredits our providers. And I'm just going to, just in the public behavioral health system. So assisted livings and things like that fall in a different administration in MDH, or Maryland Department of Health. We provide training and technical assistance. We evaluate and monitor programs. We provide funding to our local core service agencies, local addiction authorities, as well as our LBHAs. And then we have some clinical oversight over the state psychiatric hospitals and regional institutes for children and adolescents, which some people know those as RICAs. So. And then at the local levels, their function is really to look at the planning and behavioral health needs assessments in their local jurisdictions, interfacing with state and local partners. I saw that somebody from Midshore Behavioral Health was on here, Katrina. So she is one of our partners. We also have, they hold public and stakeholder engagement, training, education, information dissemination, and they manage the behavioral health system at the local levels, making sure quality assurance, if there was grievances, compliance, it would all go through them at the local levels. And this is just the map of Maryland with where all of our different counties and where.
Can I just jump in and say that each one of the counties has their own CSA or LBHA.
Yep.
Midshore is described there is the one area that is all mental health is controlled under one group. It's the 5 smaller counties on the Eastern Shore.
Yep. Okay. And then we mentioned our administration service organization. As I said before, they review the eligibility, they pre-authorize services, and they meet what we'll go over later called medical necessity criteria. And the only thing that they don't approve is the emergency room services. And some services are approved by our core service agencies, our local behavioral health authorities and local addiction authorities, but in the same platform that the ASO has. But that's right. So this is just a list of all of the behavioral health services that Russ and I will go over. So I'm not going to spend too much time going over some things. You might find you might be familiar with some of the services based off of the work that you guys do with individuals. Probably you guys would know psychiatric rehabilitation or PRP services, maybe mobile treatment or what we call assertive community treatment, which is our evidence-based practice of mobile treatment services. And so here's some others. Target case management, you might be able, you might recognize as well. And then this also starts to describe some of our substance use treatment services. So at this point, I'm going to turn it over to Russ.
Okay, so we're going to take a little deeper look at each of the services. I'll take up the mental health side, and then Priya will do the substance use disorder side. So psychiatric inpatient care. This is inpatient psych at local hospitals. There are some private hospitals, like many persons probably heard of Shepherd Pratt, and there's others at Venice, and Montgomery. But for the most part, a lot of the regular hospitals, general hospitals, have a psychiatric unit. So this is for that. You can read along with this, but it's intensive inpatient treatment, 24 hours a day, weekends. It's a great many of them are locked units for people who are experiencing severe symptoms and are at risk of hurting themselves or others. And they usually have to go, they can go voluntarily or involuntarily. Anyway, they get evaluated, medication administration and management, and then do all the gamut of therapies and have supervision and see the psychiatrist available every 7 days a week. And then they would be referring people to aftercare services. That's kind of inpatient in a nutshell. You can move on. I don't have control of this, do I? No. Okay, PHP. I know that's acronym, and it stands for Partial Hospitalization Program. Surprised that isn't spelled out. Anyway, PHP, partial hospitalization, is a outpatient short-term, but it's intensive psychiatric treatment. A lot of times these are based in the same hospitals where there is the psych unit, but this is when a person is able to stay at home at night. So they may come to the PHP, the partial hospitalization program, for the day and then go home at night. Sometimes this is used as step down from an inpatient stay, and sometimes this is used when to divert from an inpatient stay. So as it says, there's alternative to it, or help the person safely reside in the community. This is we will get into eligibility later, but this is a Medicaid eligible. This is only for Medicaid eligible. So this is, I don't believe it's covered by Medicare or uninsured status, but we'll talk about all the eligibility stuff later. Okay, so next slide. Respite services. Okay, now respite services are generally speaking to give a break to the caregiver of an individual. This is more prevalent in the child and adolescent world, and we are really only addressing the adult world right now. There have been the ability to do respite services for adults, but generally this is for when, let's say, potentially an assisted living provider, someone who individually cares for someone, and they need to either take a break, vacation, or something, and they need to have the person still continue to have the oversight. And so what happens is they can either be brought, the services can be brought into the home, or the person can go to an approved home. This is kind of rare for adults these days, but there is, this service does exist. And I can't speak a lot to it, but I know that it exists, and it is more prevalent in the child and adolescent world. Okay, move on. Outpatient psychiatric treatment. Okay, this is the big one. This is the largest service available statewide, and the most number of consumers using this service. And of course, this has its acronyms as well. OMHC, Outpatient Mental Health Center, which had different names back in the past, but that's what it's called now. And then there are others called like FQHC, the Federally Qualified Health Center. But this is where a person goes to see the therapist and psychiatrist. So on an outpatient basis. So this could be somebody who is living at home in their own place with their family, or it can be someone who's living in one of our residential programs or is receiving other services. The only one, and we'll tell you about some of the other services coming up, like mobile treatment and ACT teams, they have their own form of outpatient care. So a person is either in this or that. Sometimes it's we're trying to be clear about it, but some services are mutually exclusive. But outpatient mental health care is the large one. If a person is able to go into a clinic or go into a center and see the therapist and psychiatrist, That's what this is. And there they would have therapy, individual, group, family, psychoeducation, med management, which usually implies the psychiatrist who's going to prescribe and then see the patient, because of course with them it's, you know, the person's a patient with a doctor, and then determine whether or not the medication is effective, whether to increase or decrease. So there are, I guess there's this Health Services Cost Review Commission, HCSRC. It should be SHC CRC. And that is, I believe that's, you know, this is the regulated, okay, the regulated providers, but the HCSCRC to me was when these services are provided on the hospital setting. But they, but anyway, all the individual licensed health professionals are through the health occupations article. So the list of those professionals are, generally speaking, psychiatrists, psychologists, social workers, licensed counselors, clinical specialist nurses, and then there's other licensed providers who do rehabilitation and things as well. But this is for outpatient care. Okay, I'm sure we may have questions about it, but this is the most common. We move on. Okay, PRP. Again, this is psychiatric rehabilitation services. And sorry again for that not being spelled out at the top, but PRP is another well-known service in the community. And psychiatric rehabilitation programs are, a lot of people know them as a day program because we are going to talk about the difference between on-site and off-site. They're designed to work with people with serious mental illness. And you'll see our acronym there, SMI, for serious mental illness. And this is, so it's not designated for people that have lesser mental illnesses, shall we say. So it is we do have there is a list of priority population diagnoses, and there's other serious mental illnesses as well, because the priority population is more limited, but is really what we're talking about here for PRP services. And we'll address it more later, but this would include most of the schizophrenias and the severe bipolar and major depression, and a handful of other diagnoses that really have impacted a person's life. So as you can see here, psych rehab services in the community are done with taking the service to the person offsite, or having the person come into the program, into the day program. And so they develop, and the goals are to develop, restore independent living social skills. It's recovery. So including the ability to make decisions regarding their own life, self-care, illness management, community participation, understanding the symptoms, what triggers them, and when to and what to learn how to do those things. Plus it's community-based. So they may make friends and also do socialized things. And they have lots of groups that they attend, and curriculum for the day. And the different ones are open. The day program ones, different open. Some of them are open 5 days a week. Some of them are open half days. Some are open full days. Anyway, so this is, and they work usually hand in hand with outpatient centers and others. So anyway, we can move on. Okay, PRP services continue. This is psych rehab services, the on-site facility, most conducive to persons, promoting their participation in individual community life. They also have case management functions. We'll talk about more detail about that with targeted case management. But the basic case management functions are to assist people in securing entitlements, coordinating their services, and linking them to other services that they may need, be above and beyond, say, PRP. Okay, move on. Supported living. Okay, this is the offsite psych rehab services. So supported living services provide the in the home or in the community support, not in a day program, but in the community, in natural setting, support the individual with serious mental illness who are able to live independent housing with their family, their choice, flexible, and gives them flexible individual supports. Can teach them life skills in the home, at their kitchen, their grocery store, in their living room. Supported living services are available to individuals transitioning from RRP. Now, we haven't got to RRP yet, but that's residential rehabilitation programs. And they also are doing, they have to be a psychiatric rehab program to become a residential rehab program. The two are hand in hand, but persons who are in RRP, it's not that they're serious mental illnesses that much more, but they need more of a structured living situation and more supervision. So supported living services, these offsite services, are for individuals transitioning out of the RRP and individuals who already live in independent and mainstream housing or PSH programs. And that's one of our permanent supportive housing. This is when someone is living on their own, independent, has their own lease, but is also getting services in the home. Okay, we can move on. RRP services, something that I've worked with for a lot of years. So anyway, RRP services, residential rehabilitation program. Those services are designed for the individual with a serious mental illness, require extensive psych rehab services and support in a structured community-based home-like living environment to develop the daily living skills needed to independent functioning. So in that home, they're going to have rehabilitation counselors that are going to work with them to learn all the skills that they need. And yeah, that would include cooking and cleaning and grocery shopping and all the things that you need in a household and how to take care of your apartment or house, but also keeping time management, going to appointments. Nobody forces people to take medicine, but they monitor it. They watch each individual as they take their own medicine. But they also make sure that they're linked to their other appointments or any other services they're going to want to do, because some people want to get a job and other people's are maybe not ready for that yet. So, but RRP services are pretty thorough, and it is supervised, and there are 2 levels of care, as you can see in the second part there, intensive level and general level. And it's graduated in the sense that it's intensive level when a person has more needs. The intensive means more staffing in the home, and they're there at least 40 hours a week, and we have some that have it overnight a week. The general level is usually the staff is only coming maybe to monitor meds, but maybe they're only coming for working on services every other day, that kind of thing. When you're in an RRP program, yes, the staff do have keys and they have access to the house and the unit and the apartment, but it is still, they honor the person's privacy as much as possible. Individuals are supported in moving through the levels of residential support towards independent living. It is ultimately the goal to improve and to rehabilitate and then move on to PSH, permanent supportive housing, or independent living, or some people return to their families. Okay, move on. Should say next slide. Mobile treatment services. This is where ACT comes in. ACT is assertive community treatment. It is also mobile treatment, but it is the evidence-based practice version of mobile treatment. We have both in the state of Maryland. Some counties have mobile treatment teams. Some have assertive community treatment teams. And the larger regions, they have both. Like Baltimore City, where I used to work, has both. So at any rate, these are when a person is really not able to come into the clinic to see the therapist. This is a team approach for a person who has a higher level of need of services. This is a higher clinical need. So, I mean, we will talk about the medical necessity. There's a different one for each of these services we're talking about. But in the intensive community basis, it says assertive outreach, treatment, rehab, and support to the individual with serious mental illness who may be without a home or whose home more traditional forms of outpatient are not working for them. So a lot of times, we think about the person who can't leave their house, who might have agoraphobia, fear of public spaces. Yes, they might be able to get a mobile treatment to come in to see them. But the thing is this is really for persons with serious mental illness who need a team approach, and it will say like when most of these teams, they'll have a doctor, a psychiatrist, they'll have some kind of somatic care. So they may have a nurse as well who looks after people for their physical well-being. Then they have therapists, they have case managers, they may have a rehabilitation specialist, they may have a housing specialist, and they have peer support. So a lot of times there'll be someone who is a certified peer person who has had their own history of living with in recovery, but now they are working and they're invaluable these days. So they're the full team for the assertive community treatment. Okay.
Hey, Russ, there's a
Yes.
question. Someone wants to know if mobile treatment services and ACT services are the same as mobile crisis team.
No, they're not. And we're going to get to mobile crisis is coming up because mobile crisis, we will talk about that, but no, they're not. They're mobile, meaning that the mobile treatment can go to the home, can go to the person, but mobile crisis is a separate thing, and we'll touch base on that. Okay, then another level of care or in our system is supported employment services. This is a good one because this is, well, they're all good services, but I mean, this is one where providing the person with a person who's unable to have been able to maintain a job or has had very interrupted employment history. And for the most part, employment has been a touchstone of recovery. People who want to and can have something productive to do during the day. And a good many of us, that's employment, and have careers and things. So, but when a person isn't able to do that, it's hard to feel like a part of everything else. So support employment services are there for doing job development in place, where they assess the person, they work with them, they ask them what they want to do and what they have done and what they're afraid to do and what they think they want to do. And then they start working with what kind of job to get them. And then once they are able to get them a job, they do the job coaching and ongoing employment support so the person can maintain the job. Individuals, let's see. Yeah, it's pretty much, it's saying what I'm saying there in the second paragraph, but it's working to get people in competitive employment. Competitive, it's always been competitive and integrated. And by that, we mean it's competitive, it's at least minimum wage. And yet everybody's working towards getting people to a living wage. And then integrated in that this is not, it's not a crew of persons who have a disability working in one place together. This is persons who may have a disability or working within who are receiving services from our system, but that they are working with people who are not getting services from our system. So it's integrated in the community, and that's how we like to do housing and do employment, which are not necessarily normally medical like services, employment and housing, but they're key for people feeling and being well in their life. Okay, I think we can move on past that. Targeted case management. Now, you will not see the letters SMI on this one because targeted case management may be serving someone with a serious mental illness, or they might have a lesser mental illness or a disorder that is limiting their functioning in the community. Targeted case management is services are provided in the home or in the community for individuals to help them gain a full range of behavioral health services. This is the mental health version of what the care coordinators are doing in substance use, and also many of the other. I would like Chelsea. Can you help me out here? What do they call the Maryland Partnership Affordable Housing? We have a lot of other, and there, some of them are on. I can see they're already on this call today.
Property management company?
No. The support services.
Oh, like residences that have.
No, like for nursing homes and DD and.
Support planning agencies.
Support planning agencies, exactly. Sorry,
Yeah.
That's it. Somebody just put it in the chat.
Yeah.
Yeah, support planners are the other. This is like, okay, targeted case managers are the mental health version of that, working with the individual to link them, except maybe it doesn't go on and on. I don't know if support planners can continue with the person for a length of time, but I know that in mental health, it's designed for a shorter term, 3 months, 6 months, probably a year at the most, to get the person linked to services. So they help them with getting a medical, social, financial, linking them even to the supported employment programs, get them with benefits or counseling, education, housing. I mean, they're not miracle workers, but targeted case managers are focused on getting the person to the next level of service that they're eligible for. So they do an assessment, they do linkage, and they advocate for the person, try to empower them to do as much as they can for themselves. I mean, there have been cases where it's gone on at length, but it's mostly time limited. Okay, here's the next one. Residential crisis services. Now, the key word here is residential, but I do think I can address here, because I don't think we listed anywhere else, mobile crisis services as well. Residential crisis service, though, or what we call crisis beds, are for persons that are able to contract for safety is the term that's used, but meaning that they're not deemed such a danger to self or others that they need to be in an inpatient care, but they certainly are in a current crisis setting situation and need to be not either not homeless or not in their home where it would be worse for them. They go to the crisis beds and the crisis residential program, where they might stay for up to 10 days. It's a short stay, but it's to prevent inpatient admissions, and sometimes the alternative for that, but it also can step down and shorten the length of inpatient admissions. So pretty much a person may go into the ER and it's determined that they don't really need to be in the inpatient unit, but they might need a crisis bed for a few days. So emergency rooms can link people to residential crisis, and there's other hotlines that ones can call. I worked in Baltimore City for a long period of time, and the big program there is Baltimore Crisis Response Incorporated, BCRI. We're trying to have programs like that statewide now. There is on the BHA website, you can see there is it should still be there, a tracker that shows where all the crisis services are statewide. And there are some that are mobile crisis, meaning there's hotline, there's mobile crisis, and there's crisis beds, residential. So calling the hotline, I think it's a 211 at this point, but there's also specific numbers in each jurisdiction. And then mobile crisis, in order to go to a residential crisis bed, usually the mobile crisis team will come out to do an evaluation. So they usually are working, and if they have to, if there is any form of danger, they will come with police, usually undercover. But for the most part, the mobile crisis is usually a team, usually a couple of people, licensed professionals that will go to where the person is. They can go to the street, they can come into an ER, they can go into a person's home if they're, they have to be allowed. And then to make the evaluation as to whether the person might need to go to inpatient, might need to go to the crisis bed, or they might just need to be calmed down and then get a link to outpatient services, and they may not have previously. Sometimes families call about their loved one, but the loved one does have to have at least some level of insight to agree to meet with the mobile crisis teams. So, I mean, I know this isn't covering every nuance of crisis services, and they are offered statewide, but some areas have more service than others. Some have teams that can go virtually 24/7 doing this. Other ones, it's limited, and they may not have the overnight shift covered, but we're working towards expanding crisis services in general in the state of Maryland. This is one of the priorities these days. I think that's it. We might get questions, but that's fine. Priya, I don't know if you want to jump back in or not, but
Sure, I can jump back in. Hold on one
okay,
second. I'm gonna
great.
turn on my video. I tend to.
No, that's all right, because
My
this
eyes
is
wander.
this is the jump here between mental health, because the laboratory services are for both, but we're
Right.
going to be moving towards substance use services. So
Yeah,
Go
so
ahead.
laboratory services and drug testing, it is something that the public behavioral health system does pay for, but it has to be medical necessary to provide those tests. So, you know, it's for somebody who's on a psychiatric medication that needs blood testing, you know, provider would put in that authorization for that. Or if a person, I believe, some of the drug testing as well is also covered for these services, but again, it has to be medically necessary for those tests. So, and then we're gonna hit this. Okay, so here we start our substance use disorder treatment services under the public behavioral health services. You're going to see a lot of this ASAM acronym, and that is, I think it's the Addiction Society of American. I'm gonna have to get back to you guys about the acronym.
Yeah,
because I only know it as ASAM, and they have different levels for the services, and for each of the services, I think we do discuss it later. You have to meet a criteria to see which level of service that you need, that you would, based off the assessment, would be, I don't want to say qualified for, but would meet what your needs in that time is. So, and this early intervention services are intended to provide that assessment, education for individuals who are experiencing substance use disorders. And this is what we would call the early interventions. Referrals are made for recovery supports. So recovery residences in the state of Maryland are can be certified, but it's a voluntary certification process. The office that Russ and I work for, we oversee that certification process. So you may come across a recovery residence that's not certified, and the BHA has no, we don't have oversight over those houses. So if the recovery residence is certified and they put themselves out to be certified, you can ask for that certificate, to see the certificate or letter of compliance for that recovery residence. If you also go onto our website, we do have a contact list per jurisdiction for each of the jurisdictions, and a contact for the houses in that. And thank you, Russ. He put in what ASAM stands for, American Society of Addiction Medicine. So, and recovery residences is usually after somebody comes from residential SUD treatment, and they would go stay there for a length of time. Again, a person could stay there as long as they want, and then they would pay for that stay at that house. Maryland Recovery Network, MDRN Recovery Housing, which is also something that Russ in my office oversees. It is a partnership with our state care coordination entities, and they are at all of the local jurisdictions, and they can link an individual who is coming out of SUD services who need to stay at a recovery residence, and we would, and they would be referred to a recovery residence which is certified, and they would have access to that for time limited length of stay for 60 days initially. And then we would reevaluate after that if the individual needs to stay there longer, and the state would pay for that stay there at a recovery residence. Okay, so here we're moving up the ASAM levels of care to one which is an outpatient SUD treatment. So this includes the initial evaluation, individual counseling, group counseling, referral to ancillary services, and recovery support services. This is level 2.1 is IOP services. It's intensive outpatient services, and they're structured outpatient substance use disorder treatment for adults needing 9 or more hours of direct services per week. And it also, on the slide, it includes what that includes. So that's individual counseling, group counseling, and that ambulatory detoxification. So ACM level 1.0 opioid treatment, which this is the medication management services. So your methadone, your buprenorphine, your naloxone, that can be provided in an off-based setting by a psychiatrist or addiction medicine specialist. What is ambulatory detoxification?
I think the difference with the question with ambulatory detoxification is the difference between detoxification that must be done in a hospital setting, which is when a person is seriously addicted to something and if they're not under a medical setting where other medications can be given to them in order to help them withdraw. If the person can detox on their own, that's what ambulatory means. You can walk. I think that's all to say about that.
Thank you, Russ. Okay.
This is MAT, right? M-A-T.
Yeah, so this is your medication assisted treatment services. So then there is a partial hospitalization. This program, again, it's structured. It provides 20 to 35 hours per week, and it may be either in a community-based or hospital-based setting. So residential SUD services treatment. These are for individuals who with a substance-related disorder my apologies, are provided in correlation with the ACM levels of care. So services are provided in a structured residential environment in a combination with corresponding level of treatments and those ancillary services to support and promote recovery.
Yeah, there's the ASAM was defined right there on that last slide. And it's like, we're going to have to put the acronym full words. Never mind. We'll adjust our PowerPoint later.
So, and then these are all of the different levels that the state of Maryland offers. So ACM level 3.1, that's your low intensity. So the way that in my mind that I work it is that you start from the higher levels and then you work your way down if you're going to go through that. So you have your medium intensity level, which is ACM level 3.3, your higher level, which is ACM level 3.5, and then your intensive ACM level, which is 3.7. And again, you have to meet that criteria that's defined by ACM, and there's assessment that's that a provider would do to see which level would be the best fit for the individual. And then you also have your withdrawal management services that are available in all of the ACM levels, and they are again provided in accordance with ACM from the outpatient through inpatient detoxification. So I'm going to turn this over to Russ.
All right. Now we get to the fun part, eligibility. And hoping this will not be confusing, but it might be a little bit. But I'm hoping that we can answer your questions or get back to you if we can't answer them thoroughly here today. But eligibility is based on many factors for individual services and for persons in general. Again, this is the public behavioral health system. So with the emphasis on public, it is not for persons with private insurance through either their own employment or through their spouse or family somehow have the private insurance. So medical assistance, Medicaid, let's put it this way, Medicaid is also called medical assistance, and it's also called MA. Just so you know, when you hear those kind of terminologies, or if I even use them now, you understand they're all meaning the same thing. Okay, so full federal Maryland Medicaid, for a lot of people, it always used to be the red and white card, but that is the medical assistance or Medicaid that really drives our system and is a primary insurance force that pays for, we have a deal with the federal government where Maryland spends 50 cents, the federal government spends 50 cents. So this is the preferred eligibility, having the full federal Maryland Medicaid. Then there's QIMBY and SLIMBY, which of course are fun to say, but what it is qualified Medicare beneficiary and specified low-income Medicare beneficiary. These are strictly Maryland Medicaid programs. I think they might even be different colored cards or whatever it is, but they go with someone who has Medicare. So if a person has Medicare and yet they're, and by that I mean within our system, it's somebody who has SSDI. There's SSI, which I don't know that we're going to go into all of this, but supplemental security income. And then SSDI is Social Security Disability Income, or insurance actually stands for. And that's for somebody who worked, paid into the system, where there's other ways that people can get SSDI without being not worked, if their family member, if they were a disabled person, a child of a disabled person. But when their income is low enough, they can qualify for QMB or SLMB. And those, just to lay it out there, they pay a lot of times for the Medicare premiums, because Part A is included, but Part B, these things, Part B and Part D have premiums. So they'll pay for the premium, and they may pay for a lot of the co-pays that otherwise you must pay for under Medicare. Okay, that even in of itself is quick for that. Okay, for eligibility though, for our larger system, you have to have a diagnosis covered by the public behavioral health system. So the United States, our book is the DSM, the Diagnostic and Statistical Manual. It's 5. It's the 5th edition of this. There's also the international one, the ICD, International Code of, Disorders, I think it is. And that is already into its 10th phase. So you'll hear those kind of things, but having a diagnosis in one of those, so it needs to be, and we're going to go over maybe some of the diagnoses, but there will be other ones that are precluded, not covered. And we'll talk about that. So these are most mental health disorders are covered under our system. Okay, more eligibility stuff. You live in Maryland voluntarily, you intend to stay permanently, because some people are traveling down the coast or coming from one place to another. You have to be a U.S. citizen, or there's certain lawfully admitted aliens. Then you meet uninsured. This is the other, because if you don't have Medicaid, you might meet uninsured eligibility criteria. And we're going to go over that specifically. And that's a little more complicated because there's other choices when it comes to that. And you either are generally uninsured eligible, or there's also special conditions that we can discuss. And then you get to meet medical necessity criteria for the level of care requested. Just so that's key, because we usually end up saying MNC, but we know that we mean medical necessity criteria. So it's necessary, and there's criteria for it. And it's medical, meaning mental health and substance use as well. But the level of care, as you saw, the ASAM had all those numbered levels of care. They have medical necessity as well. But in each of the other mental health services, the inpatient, the outpatient, the partial hospitalization, the supported employment, the PRP, the RRP, the Mobile Treatment Act, each of those has a slightly different medical necessity criteria. These are all going to be, and I know it just gets a little more confusing, with the ASO, and we will show you later at the very end where where these can all be found, because you can go to their website and all of the medical necessity criteria is listed. But for a person to be eligible, he or she has either the Medicaid, has a diagnosis, lives in Maryland, is a U.S. citizen or other legal person, meets eligibility criteria, and is also meets medical necessity criteria. Next slide. Financial and medical necessity criteria. Okay, well, these are the two big things. Once an individual meets financial eligibility, either through having Medicaid or uninsured eligibility, which we'll go over the uninsured piece, because to get the full Medicaid, the health exchange where people go on to get medical, to get insurance, buy insurance in Maryland, or to get Medicaid, has an income cap. And I believe that it used to be around $1,000 a month or something like that. But SSI is even less. It's about $800 a month. Maybe it's a little less than that. So we're talking about persons that do not have a lot of income that become eligible for the full Medicaid. So, and then there's uninsured, and that's slightly different. But the financial piece is there as well. They must meet the medical necessity criteria for the level of service. Okay. So medical necessities is determined, is based on the diagnosis, what it is. And then some services require a priority population, which we're not giving out that list, but it's basically a list of diagnoses. And it does include pretty much most of the schizophrenias and schizoaffective disorders and other things of that nature. And then there's the most severe of the bipolar disorders, the most severe of the major depressive disorders, delusional disorder, I think borderline personality disorders in there, bipolar 2. It's a list of 20 plus diagnoses, but it is limited because these are considered usually the strongest or most severe of the mental illnesses. But it's not just that, because there are people who are out there living a good life with schizophrenia, and they do not need all these services. They may just need medicine, see a therapist, psychiatrist now and then. But functional limitations, some people get it where they really have a lower functioning. We'll go into some of those functional limitations also. Clinical risk. Without the service, what is the risk? The risk that you could become homeless, the risk that you could become ill, the risk that you could hurt yourself or others. Move on to the next slide. Okay, the priority population. Okay, I just mentioned a lot of the diagnoses that were on there. The person has a priority population diagnosis and meets the following, here's the functional limitations. And now these, when you saw SMI earlier for, and that was only for, let's say, PRP, RRP, psych rehab, residential rehab, supported employment, ACT mobile treatment, might be one other. A person has to have that SMI. Well, we also interpret that as priority population, and that is this list of diagnoses. But then there's also functional limitations. So they have impaired role functioning for at least a couple of years and at least 3 of the following. And these are interpretable, but still, these are clear enough. They unable to maintain independent employment enough to live a life, to have enough of employment to, pay for rent and all those kind of things. They may not. They may be able to just do 10 hours a week. That's not really maintaining full independent employment, or they may have lost their job a lot, or they lose jobs frequently, depending on their, symptoms that may occur. They have social behavior that results in interventions by the system. So, you can imagine that, and there's many of those things, because this is just a pretty generalized list. Inability due to cognitive disorganization to procure financial assistance and support in the community. They may not be able to, they don't know how to go about filling out the applications or doing anything for themselves. So they're not able to get Social Security benefits or anything. Severe inability to establish, maintain personal support system. They have no friends, maybe completely isolated, or they don't have the correct support system. A lot of times it's professionals, a lot of times it's family and friends. But if they can't maintain that, that's another one of these criteria, functional limitations. And the need for assistance with basic living skills. Some people are not adept at cooking and getting food and paying bills and budgeting and doing the things they need to do. So these functional limitations are, anyway, they're on a spectrum of how severe or less these can be, but you can see where somebody who has these sorts of things are not able to really, they need the extra support that our system has to offer. You can move on to the next page. Okay, the diagnostic waiver. This is a little caveat that's in there that we have to have for our state facilities. For the bigger things like residential rehabilitation which insists on, and the only way they'll get payment is to have one of those diagnoses. But when a person's coming out of a state hospital, Springfield, Spring Grove, Perkins, Eastern Shore, Finance Center, one of those, and they're out on they're not criminally responsible, which used to be not guilty by reason of insanity. It's still actually in the description. And they're coming out on a conditional release from one of the hospitals. They may not have the right diagnosis, but they are going to be out there legally monitored. And that this is a waiver for having the exact diagnosis. And they work it out with the administrative service organization so that residential programs and others will get paid to serve them, day programs and such. The other one is if somebody's been in a BHA, in one of the state hospitals facility for more than 6 months, and they require the RRP, and they don't have one of the priority population diagnoses. Now, excluded from this is those who are eligible for developmental disability services, because DDA is our sister entity from BHA and DDA. They would be served by that administration. So it's not that they can't be served by us, but if they're eligible for their services, they're not going to necessarily be eligible for ours. Okay, moving on. Non-priority population diagnosis. These services do not require this additional diagnosis. So outpatient treatment, pretty much any of the mental health services, mental health disorders can be served by persons in an outpatient clinic, doctor, therapist. Targeted case management, frequently the person has the priority population, or they may not, but that doesn't matter. They need linkage to get the person to have a place to live, or to get the benefits, or to be determined whether they have any disability or not. So respite services, this is if a person already has a caretaker, and this is assistance to the caretaker, and it doesn't require a diagnosis or anything. Residential crisis service, persons in crisis, it doesn't matter if they have an ongoing diagnosis, they're in crisis now. So those services don't require this. And substance use disorder services do not require these mental health diagnoses. Plenty of people have co-occurring disorders, but they don't have to have that to get into the substance use disorders. Okay, move on. Okay, and here, this is the relatively short list of excluded diagnoses. Intellectual disabilities, learning disorders, motor skills, communication, autism spectrum, tic disorders, delirium, dementia, amnestic, cognitive disorders, mental disorders due to a medical condition, sexual dysfunction, sleep disorders, antisocial personality disorder. It's one of most all of the other personality disorders, especially borderline personality, is in the priority population, but antisocial personality disorder is not. If that's a primary diagnosis for a person, we could talk about that all day too. Psychological factors affecting medical condition, relationship problems, and other V codes. V code is something that comes out of DSM. They list the non-diagnoses. So these, and I'll say this, these diagnoses, if they stand alone or are in combination with each other, they're not going to get services within a public behavioral health system. Now, if they have one of these and a priority population diagnosis or another major diagnosis, then they can. So we do have a lot of people that are dually diagnosed with serious mental illness and a developmental disability. We serve persons who have both of those. It depends on what level of care they're being served at, but they could have mental illness, developmental disability, and substance use. People have triple diagnosis and medical. I mean, it can get complicated, but these are the ones, if they stand alone, cannot be served with just these diagnoses by themselves. Okay, move on. Okay, for this, I'm having a sip of water, but uninsured eligibility. For persons who do not have Maryland Medicaid, they may be eligible uninsured persons. To be uninsured eligible, meaning that you're going to go into the ASO, the Optum system, previously Beacon, now it's Optum, where they will approve it. You still have to have the, person is eligible for those whom the cost of the medical necessity and appropriate community-based service will be subsidized by BHA because of severity of the illness and the financial need. So a person, for some reason, is not able to get Medicaid, or they have Medicare, but they cannot, they do not have the funding to pay to get the services that are needed, because it's not like you can pay out of pocket to get the services. You need to be within the system. So person is medically necessitated to have the service, but they might be outside the financial realm. There's going to be more information about this coming up. Okay, depending on the availability of state funding, service may be provided to individuals who meet specific eligibility guidelines. Okay, I think we're going to go into some of that now. The general uninsured eligibility criteria, the person does require treatment for a diagnosis that's covered within our system. They have a social security number. It's not the same thing as being a citizen, but they have a social security number. They have applied for Maryland Medicaid or the health benefits exchange. And if the individual has or expected to have an illness or a disability that lasts for 12 months or more, or SSI they've applied for, or SSDI they've applied for, or they currently have Medicare, they are a Medicare beneficiary, and Medicare does not pay for that service. Medicare has a lot more limitations on what they do pay for than Medicaid. Find providers, individual providers, most of our outpatient centers, they all take Medicaid, they can take Medicare, but when you go to private providers, some of them would rather take the Medicaid, and others, because Medicare it's a slightly different rate. But at any rate, okay, then they live in Maryland, okay, and then they're a US citizen or lawfully here. And here's the key financial piece. Gross income under 250% of FPI, federal poverty income, or FPL, federal poverty level. This is something that you would Google. Changes every year. So for 2021, it's a new number, but it's usually under 20,000 or 18,000. It's a lesser amount of annualized and then monthly income they'll look at to determine whether a person is. So there is a federal poverty level, which is cuts off at some line that is low, and then this is at 250%. So you can have up to 2.5 times that amount of income and still maybe meet the uninsured eligibility, but it's household income as well. So generally speaking, they have to look at the amount of money that comes in due to not just the individual who may be applying, but also they may have a spouse who makes money or has another disability, and that's income, or they have children, the children there may be income with the children. So anyway, yes, it seems a little complex, but saying that it's a FPL or FPI, and then you've got 250% of that. So this can include a lot of people, certain services. Move on. Okay, individuals meeting all of the general eligibility can be granted up to 2 90-day uninsured eligibility spans. So they meet all those criteria on that page before. They can get a 3-month span, and then they could go back in and get another 3-month span, 90-day span. To continue, they after the second 90-day span, with it up to a 12-month period, the individual must meet at least one of these special condition criteria. And this has changed a bit over the years, but this has been in effect something like this for at least since 2015. And I don't want it to get too murky or too confusing, but we'll move on to the next slide, because if you don't meet all those eligibility and the other thing, you have to meet some of those, but also the next one's coming up. Okay, the requesting now this Priya can jump in. This is a service required. This is a court-ordered substance use service, right?
Yes, 850, yep, 8507, 8506 is a court-ordered evaluation and treatment.
So a lot of times, like the other thing we had before, if it is the court-ordered service, you can exempt you from meeting the other criteria because they're going to say, no, the system's going to pay for it. It's only going to be for so long anyway, but the state of Maryland will pay for it. Okay, is receiving services as required by order of a conditional release. Similarly, I was saying before, if you're being released from a state facility and your income's too high or your or anything else, but you are still going to be on a conditional release based on a crime that occurred that you were not criminally responsible for, then you can be exempt. You can get the uninsured criteria and the state will pay for it. Okay, is currently receiving SSDI for mental health reasons, and they're exempt for that. So if a person has SSDI because of their serious mental health disorder, then they can be exempt from the financial eligibility, the 250% and of household income and the health insurance benefit requirements. So this allows them, because they are disabled by virtue of a mental health disorder, and they're but they have SSDI, and so they may have more money. Okay, now there's a few criteria here that we are other things that are definitely high on priority orders, and one is homelessness. So if the person is homeless in the state of Maryland, they can be exempt from the Maryland residency and from the financial eligibility. Of course, if they had enough money, they probably wouldn't be homeless, but still, they can be exempt and also get the uninsured eligibility. Another is veterans. They're exempt from having to have Medicaid. They may have nothing. They may have veterans benefits. They may have they're exempt from the medical assistance requirement, from the SSI or SSDI application piece, and even from having a verifiable SS number and financial eligibility. So we want to treat the veterans right, and they sometimes fall outside the normal eligibility conditions. Okay, and children under the age of 19. So I mean, I don't know how they pick that, because 18 sometimes is adult, but sometimes 21, but this is under 19. So up till probably the 19th birthday, if you're 18 and younger. Of course, we don't really work with children ourselves, but we do have at Behavioral Health Administration, there's a whole branch, child, adolescent, and young adult services, a whole division at BHA that we work with. Go next slide. This continues, special conditions. Person has been released from prison, jail, or Department of Corrections facility in the last 3 months. So last 90 days, somebody has been released from prison or from jail. They can be eligible as well. Uninsured eligibility. They're pregnant. Okay, that's, a person who's pregnant can meet uninsured eligibility. Also, injection drug users and a person who has HIV or AIDS. And then like the jail or prison, was discharged from Maryland Psychiatric Hospital within the last 3 months. So if you've been in a local psych unit, you were there for a couple of weeks and you were released from there, and you have no insurance, you can become eligible for the uninsured, and services can cover the cost of your outpatient. And then somebody will start working with you to see what you are eligible for. Because generally speaking, a person like that is going to need to get to the outpatient center, and it's going to need hopefully maybe a case manager who can start looking into what else they're eligible for and linking them to that. And then also, similarly, was discharged from Maryland ASAM level 3.7, the highest, the inpatient substance use treatment facility in the last 3 months, similar to the jail, prison, or psych unit. Okay, move on. And yet more is receiving medication to treat opioid use disorder. I'm guessing this is like the buprenorphine and the, I just can't
It's
think
probably
of it.
one of the MAT medications, so buprenorphine and naloxone and
Of course, the main
Vivitrol,
one.
maybe.
The one that
Oh, sorry.
people that go to the next slide.
Yep.
Oh, good. Why, it's one that's, I can't think of it, but it's the, it's the
It's-
main one. It's been around for the longest time.
Yeah, it's Friday. It's on another slide when we get to the.
It's on Friday. It's Friday. That's good. That's a good excuse, yeah.
I'll go back and we'll look at those.
Sure, it'll come to me because it's like, okay, so it's opiate. Never mind. It's not an opiate. It's instead of. Okay. So if they're in medication-assisted treatment for opioid use disorder, and trust me, the opioid epidemic and its response is a huge priority of the state of Maryland. Is also requested. The next bullet is requesting one of the following services: supported employment, residential crisis, respite, or Maryland recovery net housing. These things are not, does not require the uninsured eligibility. I mean, you can be, they meet the special criteria. So we want people to get into employment, and then has received special exemption from VHA. Well, that's special exemption. I'm not sure exactly. That could fall under a lot of different things. One other thing I know that's not in here is EID. And I'll just say this, that if a person is loses, let's say they get a job and they and now they have supported employment and they have somebody helping them, they can be eligible for employed insurance for persons with disability. It used to be called the Medicaid buy-in, where a person can actually purchase medical assistance. It's a special thing for persons who are employed. They have to show proof and pay stubs and all sorts of things. And of course, they're not making a lot of money out of it, but they're still making enough money that they can continue getting medical assistance. Anyway, then I think the next slide is going to be just a quick eligibility summary.
Yep. I'll give you a chance to take a sip of water there. As Russ went over all of the eligibility summary, again, the person has to meet Medicaid, have Medicaid, must meet our eligibility criteria, or they must meet eligibility for uninsured. The key words there are the medical necessity criteria for the level of service required, which goes over the diagnosis, their functional limitations, and their clinical risk. That's just a nice summary of everything. I know that was a lot of information that was kind of given to you guys at once. I wouldn't expect anybody to kind of remember everything that we said.
But I hope you guys,
yes, or at least be able to know enough to ask the right questions when you guys are, if you're trying to help somebody access their services, where, what to say, kind of some key phrases to assist that individual into getting connected to services. In terms of service access, which if you are helping somebody to access services, these are your two key main point of contacts. Like we said, the core service agencies, the local addiction authorities, and the local behavioral health authorities at the local in the local jurisdictions are going to be the ones that can help you the most in terms of what services are in your area. And if you guys reach out to them with as much information as you can give in terms of what services the individual is willing to accept. Is it one of those things where someone needs to go out and kind of talk to the person to see what services they would be interested in? So they would be your best bet in terms of linking you to a provider that can go out and see people. And then
their nickname is MABA.
Yes.
The MABHA, the Maryland Association of Behavioral Health Authorities, and the organization that oversees them is MABA. And it is, so that link right there will take you to, it has, you pick the county you're in, that person you're serving, and it'll link you to the CSA, LAA, or LBHA for that county.
Yeah. And then our administrative organization, that website, if you go to maryland.optum.com. It will give you so much information, more information than Russ and I have provided you today in terms of when Russ was talking about the priority population. It'll give you a list of the priority population diagnosis. It will give you the eligibility kind of medical necessity criteria for each of those service line items that he was talking about. And just good summary, pretty much any of the information we got here is going to be on that website under the provider manual. And if I will in a second stop sharing and show you guys that website.
I want to throw in there just for a second that the one and if you're going to show it, perfect. The provider manual, which is part of the Optum's, it's the key. It's going to probably be a tab that's on their website. So when you can see that, you can, it says the description of each of these service lines, much more detailed description, and also the medical necessity criteria to receive any of those services.
Okay, can you see the screen? Okay, cool. So this is Optum's website. If you go under behavioral health providers, you're going to see manual. And if you go under the manual, you'll be able to, they have a level of care appendix, medical necessity criteria link, and the whole manual is up there. But the level of care appendix, I think it has nice hyperlinks and can take you to, if you're interested in opioid treatment services, who's eligible for those services, and who's eligible to provide these services, reminders, things like that. So it's a little bit probably more intensive. I'll drop that link also into the website or into the chat box. So you guys have.
They also have the fee schedules in there. And what that means is how much every single service is, what it costs. And so for the most part, so the difference with the Medicaid and the uninsured is that with Medicaid, we it is a 50-50 match with the federal government, and so that saves the state of Maryland and all of us taxpayers quite a bit. When it is uninsured eligibility, it is state only dollars, so it is Maryland paying for the full amount. So it's okay. I mean, it's like if the person's eligible, they're eligible. They don't have to have the Medicaid, but at any rate, that is the difference between having Medicaid and having, let's say, Medicare with SLMB or QMB or one of these other uninsured where you don't have any insurance. So, questions?
Yes.
Right.
Yep. Where are the questions? That was the.
You in there with us?
I think I saw somebody raise their hand, Chelsea, but I don't know what to do if they raise their hand.
Did somebody raise their hand?
I thought so.
Oh, I have two call-in folks. I'm gonna allow someone who called in from 410-274-3744. If you have a question, I'm gonna unmute you. You have permission to talk now. You should be able to unmute yourself. Do you have any questions? Okay. All right, and then another call-in person from 435-503-8807. I'm going to allow you to talk if you would like, and I will unmute you. If you have any questions, feel free to ask them.
Hello, caller, you're on the line.
Exactly, it's kind of like that, actually.
Friday afternoon.
I know. I'm not seeing anything.
It is Friday afternoon.
Well, hopefully we were not as clear as mud. I mean, I'm hoping that the way we presented it was understandable, because
I just put
it is complicated. It is complicated.
Yeah.
I mean, want persons, it's not just people who have low income, it's persons that have the need for the service, and it's based on a variety of eligibilities, and certain ones, certain services are for only persons with a serious mental illness. And
Yeah,
then we have some services you can't have two at the same time, because
right.
you have a case management, you have PRP. No, the PRP is supposed to do the case management. You're in the residential program, you can't have the ACT team because you have already a complete wraparound services.
Right.
So there is a question in the question and answer box. I was told that someone can only be referred to an ACT team from the hospital. Is that true? I don't believe that's true. They
That's
have
not
to
true.
meet that medical criteria and meet that diagnostic, but no, that's not true. It is probably historically, it has ACT teams probably have a higher, if you look at the individuals they served, are probably individuals who've been in and out of the hospital. So I'm not sure if people are getting that mixed up. They
But then
probably
again,
have.
when you're talking about the hospital, it could be the ER, but you don't have to be medically cleared, which is what the ERs do to send you on to the next level. And if you're talking about inpatient psych, it's one thing. But if you're talking about somebody coming out of the hospital for any given medical reason,
No.
when you say hospital, I mean, you're probably referring to inpatient psych unit. Their referrals, they should be referring out, but a lot of times they make a referral to the outpatient mental health center, and a person may need more than that. So ACT team mobile treatment is more than that. They're able to go to the person, but it doesn't have to, the referral doesn't have to come from a hospital.
I have a question for you guys. Is there a limit on how much case management somebody could get? Like how many sessions that a person could get?
Yes, in the course of a month, there is actually, for targeted case management, there's 2 levels, intensive and general is what they've chosen to pick. And the general is where you're going to have like two times a month with a case manager, and the intensive is like 5 times a month case manager. Now these are minimum, so they can do more, but they can only get paid for that. So I hate to say it, but a lot of times in our system, services should not be done this way. But a lot of times when there's a minimum standard, that you'll find that there's providers, many a provider will only do what they're going to get paid for. But a lot of times it's a minimum standard, and there are providers that will go above and beyond and do whatever it takes to help the person. There's a sense of investment in the client they're working with.
Gotcha. There's a question here from Lucienne Parsley. I'll go ahead and just read this. What happens when you have someone in the community who needs intensive RRP services but has not been in a state hospital? I have someone who's been in a crisis bed for months because he can't access an RRP. He does not qualify for an ALF. He has SSI and MA. Told by the LBHA that BHA is prioritizing for intensive RRPs only persons discharging from the state hospital. He's discharged from inpatient in a private hospital where he was for 18 months.
Thanks for your question, Lucian. A person can be, there are community waiting lists for RRP. Within a jurisdiction, a person can submit an RRP application to the LBHA or the CSA, and they can be considered eligible, meet the criteria, and be on the community waiting list. The priority is, and there's a whole RRP referral process for this, where the state hospitals do have the kind of like the first dibs at for the first number of days of a vacancy's existence to make a referral to it. Currently, we're under a lot of pressure to get people out of state facilities, but if they don't have anybody ready to go for a given RRP bed in a given county and a given provider, within a week, the local authority is going to move on to their community waiting list. And the community waiting list is persons who are not coming out of state hospitals. And of course, even there, we want them to prioritize responsibly, so that if a person is living with their family and there's not a high risk, they've got a roof over their head, things are going well. Your guy is not like that. He's in a crisis bed. He may have to be homeless. And of course, that's one of the issues in crisis beds, is when a person is homeless, and then it's difficult to find a place for them to go. And crisis beds are their own kind of priority. And mental health court is, and drug court is, and the ASO has a high inpatient utilizer list. So there's other priorities of the community referrals. We do maintain that the state hospitals are a high priority for our intensive level beds, but it's not that a person is only going to go to a general level from the community. They can go to intensive, but we are going to hope that our local authorities are exhausting their state hospital list, because sometimes they may have people waiting from the state hospitals, but they're not ready to go. Takes, and the provider, of course, wants the bed full, and we want somebody from a state facility, but if the match isn't being made, nobody wants to move to this county or whatnot, then they move on to the community wait list. Now, if he should be on a community wait list from whatever his county or jurisdiction of origin is. The RRP application should be submitted to that. And if he's eligible, they should be on their wait list, community wait list.
Okay, and also I just wanted to point out to everyone who's attending, Priya shared a link in the chat.
I shared a couple links. One is to Maryland opt-in.
Mhm.
One is to this Maryland, the Maryland Association of Behavioral Health Community. So that's all our CSAs, our LBHAs, LAAs, so the local addiction authorities, all of their information is in that second link. There's a link. The third link is a crisis resource link. And then the fourth link, the telehealth behavioral, is resources on the administration's page in terms of telehealth and accessing services. So, and then I'll put in a general BHA link. So.
Okay, great.
And our website, I mean, it should be in there too, right? Yeah,
Yep.
I'm sure. Yeah, there you go. Yeah.
So, and there's also COVID-19 resources, things like that. If you guys need more COVID-19 resources than you already have.
Certainly, and actually the pandemic has been something we've all had to contend with, all of us in our lives, but certainly has impacted a lot of the services, staffing, and especially the congregate living settings, of course, as it has everywhere. I think we're already past time here, but
Yeah, so we can go ahead and wrap up.
There's one more question, but that's not really, do you have any input on those to serve those who do not meet? If you're at community also require individuals have
we think of Stephanie for these things.
Yeah, that's not so Russ and I are kind of indirectly involved, and not, if you're asking if Russ and I are decision makers in terms of that level of care, we're not. I don't know if that's what you're asking, Karen.
The community waivers.
It sounds like
go ahead.
Yeah,
so we're not, we would not be do you have any input on how to serve those who do not meet nursing home level of care? No one is required 24/7. So that is That's a tricky question in terms of 24/7 assistance. So you're
Karen,
asking
where do you work, Karen?
for individuals who work.
Maybe she's one of your sport planners. Maybe, I don't know.
Karen may have. Oh,
Oh, okay.
Passar.
She works for Optum Maryland Passar, so she works with Stephanie.
Oh. Oh,
So we
okay.
work. So Stephanie's
Oh, then
in our
you're
office.
offering this. You're talking about this as a.
You know, she's asking if we have any resources to help with the 24/7 assistance gap, I think.
I mean, so we have some people who are in our housing programs who have to hire aides to assist them to live independently in the community. And so I can contact, and some of the supports planning agencies also might be able to get this information. If they have a person whose level of care changed for some reason, like when they moved into the community, that does happen, obviously, because it's a new, different transition, and they will get, reevaluated essentially. So we've had people in that situation, and they've had to hire aides to come in, and it's also possible that one of the centers on independent living might, for where this individual lives, might have some resources or information to share on that as well. So they work with people with disabilities who are living in the community, or are trying to seek different kinds of resources and options.
Yeah, no, I mean, I definitely think that, as comprehensive as our services are, there's definitely, room to grow, to serve, to be able to serve it.
Right.
To serve more. So sorry, Karen, I don't think we really answered your question. I'm trying to think if there are services that would help you, but I can't think of anything off the top of my head that would cover that 24/7 for someone who lives independently in their housing.
Yeah.
No Stephanie O'Day, right? We assume so.
I think so.
Who is our older adult and long-term care?
Stephanie would be a good person for her to talk to.
Yeah.
So, Karen, I'll put my email in the chat if you want to connect with me after this. That's fine. You can send me an email. Anybody else?
If people have questions for Russ and I, if we don't know the answer, we'll definitely point you in the right direction to someone who can help you answer the question better than we could. So we will find the answer for you.
All right, well, thank you everyone who attended today's session. This was recorded for those of you who want access to the recording later. It will be emailed out to attendees, but I'm also going to upload it to the Department of Disability's YouTube page. So you can also view it there. And I don't know how to edit videos, so just scroll through to what you need. I don't have somebody to help me edit videos at all, unfortunately. However, the information is extremely helpful. So as long as you just pass the sections where we're just having conversation aimlessly, then you'll get all the content that you need. We will also be sending out the PowerPoint presentation following this session. And again, if you have any questions for our panelists after the fact, and they need help with getting connected to resources, my email's in the chat. I can connect you to our panelists if, you know, a specific question related to behavioral health services. Thanks, Karen. And
Priya, how about if I put, how about if I work on the PowerPoint to put in, because there's a lot of acronyms there where it's not spelled out when you first see PHP, PRP. It doesn't even say what it is.
Yeah.
like an
I think
acronym
we need this to be
yeah.
viewable by the layman. You know,
Yeah,
anybody
we
who.
read it, and unfortunately, when we were reading it, since we understood what we were reading,
Yeah, I know.
didn't catch
we
that.
didn't even go. "Ah." Of course.
That
So
often.
you have to know your audience.
Okay.
You know, I mean, that's always the key thing.
Yeah,
So
if you put
we
that
may
together,
do
Russ,
a slight alter on our
yeah,
preparation on our PowerPoint, and we'll get it to you.
I can send that out as well, an acronym list or something. So
Yeah, we have one of those as well. I haven't updated it since a couple of years, but you know, what new is coming on.
No, we appreciate everybody taking your Friday afternoon and, you know, letting us talk to you guys. This is a little different than if it was in person. But, you know, we are glad to share the information. If there's any like a service line item or something that you want us to go into a little bit more deeper, let Chelsea know as well. And we'll find, you know, if it's Russ or I, or if it's somebody else in the department, we'll reach out and ask them if they would present for you guys in terms of a little bit more specific, since this was very much a very bird's eye view into the public behavioral health system. There's so much more that we probably could have gone into. It's just, I was getting, we were trying to be mindful of the time. So,
all
which
right,
I think we were over now.
Thank you, everyone. Have a great weekend.
Good weekend.
Bye.
Bye.